Now I'd like to take you for a guided tour of the airway. And I find the best way to do this is to look at it in an anatomical relationship perspective. So the CAT scan is an amazing tool that gives us a three-dimensional image of human structures, and they show us the relationships between structures that we might not otherwise see in diagrams without looking at them in real human beings. So we're going to walk through CAT scan images. It's a linked series showing basically the airway from the top of the nasopharynx, really the sinuses above that, all the way down to the diaphragm. So sit back, relax, enjoy, and we'll work our way through. As an orientation to the CAT scan, for those of you who aren't familiar with them, I've marked right and left. A CAT scan is obtained by putting a patient through a tube that shoots X-rays essentially in 3 dimensions in slices, and the computer processes those and puts the images together to create the 3-dimensional images. And we're looking at the patient from the feet up. So it's as if we put the patient through a deli slicer and we're looking at them from their most inferior view. So the R is the patient's right, the L is the patient's left, the bottom of the screen is the patient's posterior, the top of the screen is the patient's anterior structures. So in this case, what we're seeing is on the patient's left, and from here on out I'll just say left and right to refer to the patient's left and right. You can see an ear, you can see that area that looks like cobwebs, that's the mastoid airspace. The big gray central area surrounded by white is the brain. That surrounding white, high intensity white, is bone. Anteriorly, you can see the patient's globes of the eyes, the eyeballs in the eye sockets. That central area that's black surrounded by white, those are sinuses, and the white is high intensity bone. Black of that color is air. So we're going to move through this now and look at these various structures. And now, as you look anteriorly, you see the bone of the nose, and you see some bone that is traveling posteriorly. And then there's a little bit of gray behind that, and that gray is soft tissue, and there's 2 black lines running along that. And that's the top of the nasopharynx. You're still in the bony nose at that point. Most of the nose is cartilage, but the most superior portions are bone. And you're starting to see the air spaces of the nasopharynx. Now, surrounding all of that are sinuses. And you can see that those are bone and soft tissue. And the purposes of sinuses are to make your skull lighter. It's already about 20 pounds in an adult. If all the bone was solid bone and not full of sinuses, you'd add a significant greater amount of weight and it'd be very hard to hold your head up. Now, from a pathologic perspective, if you take a look at the patient's right orbital wall, you can see how there's bright white bone right next to the eyeball, and if you follow that posteriorly and medially, you see that there's a disconnect. And if you look at the opposite side, you see that the bone is continuous. So that patient actually has a bony fracture there of their orbital wall. So let's keep going here. You can see now the nose is beginning to extend out just as soft tissue. We're getting below the level of the bony nose. You can see the septum, the central area, is becoming more clear. And now, in the black areas of the nasopharynx, you're also starting to see these gray structures, and those are turbinates. And turbinates basically are mucous membrane covered cartilaginous structures that protrude out into the nasopharynx, and their job is to basically be sticky mucous membrane surfaces to catch debris, to act as filters basically. They help to humidify and to keep humidity from escaping the nose out into the air, so you're not losing a lot of water that way. So it humidifies the air because there's the air in your lungs is very high humidity, almost 100%. And they also have a lot of blood vessels in them, so they serve to warm the air. And beside those, you can see the maxillary sinuses, air-filled on the left, and on the right there's some fluid in that's related to that fracture, because that's also a fracture apparently of the wall of the sinus. So let's continue to follow this down. Turbinates become more clear, and now you can see the back of the septum where it ends, and in almost the middle of the CAT scan you see a large black area, and that's the posterior nasopharynx, and that's where you have just one space. It's no longer two separate nostrils, but one space in the nasopharynx, and that connects down into your posterior oropharynx, or your throat, the back of your mouth. So we'll continue to follow that. And now you see this white solid structure coming in first on the left. Now it's completely covering the left nasopharynx, and now the right as well. And it looks a little uneven just because the patient's head was turned slightly when we got these cuts, so they're not perfectly uniform. But we look here, and then here, you can see that's the same structure. That white structure is your hard palate. That's the bony structure. You put your tongue on the roof of your mouth, press on it, it's that hard structure. And behind that is the soft palate, which is soft tissue. And that separates your mouth, your oropharynx, from the nose, the nasopharynx. And during pregnancy, when you're developing as a fetus, originally that's an open space, and then the palate closes through there. So people with a cleft palate, that's partially open, and that can be open all the way out to the lip at its most extreme. So you see those structures basically separating the nasopharynx from the oropharynx, and you can see it's a flat structure. It sort of comes in suddenly on this cut, there it is, now it's gone. So that's the base of your nasopharynx, and so when you're putting in an airway through the nose, you're sliding it flat along that, and going back you can see everything else is kind of full of turbinate, and then there's a space, and then there's that. So you want to stay as close to that as possible when you're putting anything in through the nose. So now we're into the oropharynx below the bony palate, and you can see the alveolar ridge, the bones of the face that make up where your teeth go in. The teeth are in that bony ridge, the alveolar ridge. You can still see some of the soft tissue of the soft palate there, dividing the posterior nasopharynx and oropharynx from the anterior oropharynx. Those two white lines on the side surrounded by the light gray is muscle. Those two white lines are the bones of your mandible or your jaw. They come down as thin structures like that, going superiorly to inferiorly, and then they'll make a 90-degree turn that we'll see. That 90-degree turn then is where the jaw comes forward. Now, one other interesting thing to notice here is that you've got, as you're looking at the center of this, you've got your cervical spine. And the structures you're seeing here are your first cervical vertebrae, which basically articulates with the base of your skull and lets your skull rotate forward and backward. So, and then in the center of that, right here, we've got your odontoid, and that's a bony structure that comes up from the second cervical vertebrae, and you can see it comes into the first cervical vertebrae, and that allows the neck to rotate and the head to rotate around the neck at that point. Now, just a little bit posterior to that, you can see the spinal cord. So it's in the spinal canal, but that bone shares that space. But what's more important is right in front of the atlas, first ring of vertebral ring there, you can see how very little soft tissue space there is between that and the posterior nasopharynx. And that space can be filled with blood or with infection, and if that happens, you can actually end up compressing the airway. And you'll see that that very close relationship continues all the way down to the level of the vocal cords. So pay attention to that as we're going through. And you can understand why what's called a retropharyngeal abscess, and an infection with pus forming it in the space between the back of the airway and the spinal column, can significantly compromise the airway. So we're going to keep moving through here. Now we're seeing a big gray structure showing up in the oropharynx. That's your tongue. And interestingly, you can see that overlapping that, in a sense, is the very posterior most elements of your soft palate. And so that little triangular hanging down looking thing is the uvula, that little dangly thing that hangs down in the back of your throat. This patient happens to be laying on their back, so it's dangling backwards. But it's actually lower than the level of the tongue here, which is interesting to note. And when you look in someone's mouth, you may not be able to see the back of their throat for that reason. If their tongue is so large and their soft palate hangs down so far, you may have a lot of difficulty seeing the back of their throat. Take a look now also at the mandible, the jaw. You can see that it's starting to extend forward, and it will do so quite a bit more as we go through here. So we're still seeing the tongue. We're seeing a little air under the tongue there, just like you have air under your tongue if you lift it up. And there's the jaw. It's coming forward. So let's move back again there. Tongue, air, jaw coming forward. And now, in the midline, you're now into your pharynx. That's the black open airway space. And air and food and everything you drink cross in that space. And so that's a very busy space, and you coordinate quite a bit to make sure that things don't go down the wrong tube. The esophagus, which lies posterior, or your larynx and trachea, which lie anterior. Now, in the middle of that black space, you're seeing a little upside down, almost like a V-shaped, or like a hat in the center of it, and that's the top of the epiglottis. So we can scroll down, you can see it becomes more clear. It's attached to the back of the tongue. There it is, all the way up there. The epiglottis, we used to think it was the primary thing that protected your airway, that kept food and water from going down. We don't think that anymore. You can do video laryngoscopy and watch people swallow. The epiglottis probably played a very important role when we, as developing species, spent more time in and out of water, and this was a way of sealing off your lower airway structures to protect you from drowning, essentially. Now, it's one of the things that probably protects your airway to keep you from aspirating, getting things into your lungs, but it's not the primary thing. The primary thing actually is movement and closure of the vocal cords, coughing, gagging, and using other structures as well. Now, the problem with the epiglottis, from your perspective, is twofold. One, the epiglottis can get infected. That's called epiglottitis, and that used to be a life-threatening illness in kids. And so a child would get epiglottitis. This would be swollen here, and it would swell and cover the airway because the airway is relatively small for kids. Now, because of mostly Haemophilus influenza B vaccination that kids get, they don't get epiglottitis much. Epiglottitis is now a disease of adults, and the average age of the person now who gets epiglottitis is about 39 years old. And for an adult, this presents more as a sore throat with fever and feeling bad, but because the airway is relatively larger, very rarely can the epiglottis swell so much that it completely blocks the airway. The presentation for these people, everyone that I've ever seen, basically they can point right to the center of their throat, just above their voice box, their laryngeal cartilage, and say, it hurts right here, I have a sore throat, I've got a fever, I've got swollen lymph nodes, and then we get a CAT scan and we find that they've got epiglottitis, or we get an x-ray, or we put a scope in their nose and we look and we see that it's swollen. But either way, it typically doesn't block the airway, but it's still a bacterial infection, and it's a bacterial infection in the airway, and we need to take it very seriously. So we've got to think about the epiglottis. The other thing that can happen with the epiglottis is if you're putting in a blind insertion airway device, a laryngeal mask airway, a king airway, whatever you use, you can potentially fold the epiglottis over, and if that happens, you can in fact partially obstruct the airway. And so good insertion technique helps to prevent that. Now, one other thing that you're seeing is some bony structure starting to come in right beside the epiglottis. And let's go down. There, you can see it comes right across the front. That is your hyoid bone. And the hyoid bone is very interesting. It's the only bone in the body that doesn't articulate on any other bone, so it doesn't actually touch any other bones. Instead, it's got ligaments that attach it to everything in your airway. The hyoepiglottic ligament attaches it, you can pretty much see that right there, from the hyoid to your epiglottis. It attaches to your jaw, it attaches to your tongue, it attaches down actually almost to the level of your collarbones. It attaches to everything. And so it's often referred to as the master bone for airway management. And that's because wherever you move that, you will move the soft tissues of the airway. And so if you're trying to decrease turbulence, if you're trying to open an airway, you will lift it anteriorly. And that is an incredibly useful thing to be able to do, because when you do that, you lift up all those soft tissues and you open everything up. Because here's an interesting finding. We've often thought that the most common cause of airway obstruction in the unresponsive adult is the tongue. You've probably been taught that in first aid and CPR classes. Well, in 1995, a couple of anesthesiologists did a study. And how they got this through their institutional review board, I'll never know, but this is pretty cool. So they took patients, they sedated them to the point where they lost all their airway reflexes. They were essentially unresponsive. And they did an MRI. And they MRI'd the upper airway to about the level of the vocal cords. They were looking to answer the question, what actually in adult patients obstructs the airway when the patient becomes unresponsive? And it turns out the tongue drops posteriorly, but doesn't touch the back wall. It doesn't obstruct the airway. In fact, it just causes turbulence. What does obstruct the airway is the nasopharynx with the soft palate that falls backwards and obstructs the nasopharynx, but you've still got an open oropharynx. And the oropharynx is the epiglottis that falls back and actually obstructs the airway. And so if we do a jaw thrust, if we do a head tilt chin lift, and we pull up on that bright white bone in the front there, that's the mandible, the jaw, that's attached by ligaments to the hyoid. We pull the hyoid up, we lift the epiglottis up, we open the airway. So when you're opening an airway, think about exactly what you're trying to do, and what you're trying to do is move that hyoid forward so all the other soft tissues pull forward. There are techniques described of putting a safety pin through an unresponsive patient's tongue and pinning it to their lip to open the airway. That will do nothing to move the epiglottis. It won't move the hyoid. So it's an ineffective technique, and you end up getting a lot of blood in the patient's airway. And again, one other thing to look at this level is that close relationship between the body of the vertebrae and the back of the airway. There's not a lot of space in that soft tissue, so infection can be a real problem, or blood, or anything that causes swelling there. So we're moving on down here, and now you're seeing another structure starting to show up that's curved, shield-shaped almost, in front of the airway. But it's not real bright like bone. It's a little bit fainter, but it also looks like a V with the point of the V pointing forward. That is your laryngeal cartilage. If you put your finger on the front of your throat and feel your voice box, your Adam's apple, that's the laryngeal cartilage. And that's a V-shaped cartilage, and that's what is the entrance to your larynx, which is your vocal structure, and the vocal cords divide the upper airway from the lower airway. So looking at this, if we move through these structures, now we're seeing the vocal cords right there in the center, and you can see the laryngeal cartilage. And sorry that jumps there. That's two separate CAT scans. One was a head CAT scan. The first one was a head CAT scan. Then we go to a neck CAT scan, and then we'll jump to a chest CAT scan as well. But you can see the laryngeal cartilage in the front, and those tissues kind of coming in from the side. And those are folds of skin. Your vocal cords are not cords like guitar cords. What they are webs of soft tissue, not skin, but soft tissue, that come in from the sides of the laryngeal cartilage. They attach to the laryngeal cartilage along its length in the front. Now you see the laryngeal cartilage is open in the back. Well, your cricoid ring, the next cartilaginous structure down, and we'll see that shortly, has it looks like a signet ring, and that is, it's got a ring structure in the front, and then the back actually has a pointy extending piece that extends superiorly in the back of the V made by the laryngeal cartilage. And you can see it right there. And so those folds attach to that in the back. And by moving the laryngeal cartilage forward relative to the cricoid ring and moving the cricoid ring and that protuberance back relative to the larynx, you tighten and loosen the vocal cords and you change the pitch of speech. So that's a very important structure for communication. It's also a very important structure for the airway, because right now what we're looking at is the glottic opening. We're looking at the vocal cords here. That's that little elongated oval-shaped black structure right in the middle. That's your airway. That's your vocal cords. That divides the upper airway from the lower airway. And so now we keep moving, and boom, we're below the vocal cords. Everything opens back up. The laryngeal cartilage ends, and you can see the ring of the cricoid cartilage. It's that very faint gray ring. The cricoid cartilage is the only complete ring in your trachea, in your airway there. And so that's also important for several reasons, and we'll talk about those as we look at the rest of the trachea. But I want you to take a look at the space between that ring and the bottom of the laryngeal cartilage. There's a laryngeal cartilage, it stops, there's a little space in that ring structure there. And if you take your finger and you slide it down your laryngeal cartilage, you'll find a little divot. If you push on that, it feels soft, and then there's a solid structure behind it. That's called the cricothyroid membrane, and that is the space that we would cut a hole through if we needed to access the airway below the level of the vocal cords. So if somebody had a foreign body obstruction above the level of the vocal cords, if somebody had what's called angioedema, or they had swelling from an allergic reaction, or they had airway burns and they had obstruction above the level of the vocal cords, that's the spot that we would cut through. And you can see it's very close to the skin. It's very easy to access. And because of that solid ring of the cricoid right there below it, with the cricoid cartilage extending superiorly, almost forming a backside to the airway there, if you get in there, you can go through and through, but it's a little harder because of that cricoid cartilage in the back. It's giving you protection in the back and making sure you're in the right space. So that makes that structure a very important one in terms of airway management, and one that you should know well. So what we want to do now is go a little bit further down the airway. And as you can see, the trachea is open again. We're below the rings. So we follow the trachea down. And now if you look from here, where you've got a complete circle in the cricoid ring and no cricoid ring, and now you've got a divot in the back of the trachea. And that's because below the level of the cricoid ring, the trachea is actually made up of C-shaped or horseshoe-shaped cartilaginous rings that are open posteriorly. Now you're looking at this and you can see the big open space of the trachea, and you can see the bones of the vertebrae, which you'll note are almost anterior structures at this point. Between those is the esophagus. It's completely collapsed down right now because the patient's not swallowing anything. But imagine if you were swallowing a chunk of food and you're in that space between the vertebrae and the back of the trachea there. If you had solid rings, that food would bounce off each of them, clunk, 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 as it went down. So instead, you've got that not solid ring, you've got the opening in the back, and so the esophagus can push slightly into the trachea, but that can become problematic with a very large food bolus. Even in the esophagus can make a person feel like they're having trouble breathing because it's pushing into the back of the trachea. It won't obstruct it. The cartilaginous ring, the horseshoe there, will hold it open, but it can be pretty unnerving for a patient. And you can see the relationship between the spine and the airway is still pretty close. And we're in the neck right here. So while you're pushing on the back of your neck and you feel like you're pushing on the spine, this is just above or just about at the level of the shoulders. Your spine is really deep there. And you see some other structures too on here. So to the left, the patient's left, on the left you see that bright white structure, that's the clavicle or collarbone coming through, and the farmost left and posteriorly you're starting to see the top of the scapula or the shoulder blade. So let's move further down through the airway here. See the shoulder joint there on the left forming that curved bony structure is the head of the humerus. Keep moving down here. Collarbones coming around in the front. All right, now we're down into a chest CT. Collarbones coming in on the front. And look, you're looking at the level of the collarbones. Look just to the patient's right of the vertebra, and you see that sort of dark gray area. That's the top of the lung. Right there. So the top of the lung is really at the level of your collarbones as they come anteriorly, which means that a stab wound or a puncture wound right above the collarbone can actually cause a lung injury. All right, so we're following the trachea down. We see the lungs coming in right and left on both sides. Now right here, right before we transition from soft tissue to lung, remember that the lungs are surrounded by pleura. And the pleura are basically a two-layered sac, just like the plastic bags you get at the grocery store to put your vegetables and fruits into. So you take them off the roll and they're stuck together. They're held together by electrostatic forces. They're not physically connected in the sense of being the same structure. There's a potential space inside of them. And the same is true of the pleura. You have a parietal pleura, or some people would call it a costal pleura, that attaches to the chest wall. And then you've got a visceral pleura, or pulmonary pleura, that attaches to the lung tissue itself. And the same sort of forces, electrostatic, water tension forces, hold those two together. But there's a potential space between them. And just like if you rub that bag and pop it open and you drop a piece of fruit into it, now there's something pushing those apart. If you get air or blood or pus or cancer cells or anything else into that potential space, you're now holding the two sides apart. They're no longer connected. They no longer interact. Why is that important? Well, when you breathe, you expand your chest wall. You flatten your diaphragm, and you've got parietal pleura attached to the diaphragm, to the chest wall, and actually down the inside as well on the mediastinum, the structures in the center of the chest. And so your parietal pleura is physically attached to those structures. The visceral pleura is attached to the parietal pleura by the electrostatic, by the water tension forces holding them together. So when the chest wall expands and the diaphragm flattens, the parietal pleura is pulled out, the visceral pleura is pulled with it, and because it's attached directly to the lungs, it expands the lungs. Well, if you disconnect the visceral and the parietal pleura, you put something in that space, now the chest wall expands, the parietal pleura pulls out, the visceral pleura doesn't, and the lung doesn't expand. And so that causes a real problem. You no longer have your mechanical bellows, you're no longer decreasing intrathoracic pressure, you're no longer sucking air in, so you can't ventilate with stuff in that space. Now looking at the lungs itself, the highlighted white are blood vessels running through the lungs. You've got your smaller and smaller pulmonary veins going down to your pulmonary capillaries, and then you get your gas exchange, and then they become pulmonary arteries and go back to the left atrium. And you'll see those throughout there, but they follow the airways and the septae that divide up the lung, and so you'll see the lung itself looks like it's divided into a little honeycomb, and in a lot of ways structurally it is. But we're focusing on the airway here, so we're going to follow the airway down. Now you're seeing the airway is moving more and more posteriorly, and there's stuff that's appearing in front of it, bright white stuff. Those are blood vessels. And the one in particular that you're going to notice here is this one that's coming in just to the left of the trachea. And you can see it becomes this big long structure. That's the aortic arch. So the aortic arch comes medially or midline out from the top of the heart. We're in the heart now. Look at that big bright white structure. We'll go back up it, comes across, crosses over, forms the arch, and then it descends to just to the left of the vertebra there, left to the vertebral column, and follows down as the aorta. Now the other structure that you can see here, where you're seeing the aorta, is just that little tiny irregular shaped black structure just to the left of the trachea. And that's the esophagus, so it's slightly open there in that view on this patient. But you can see that the trachea itself is still horseshoe shaped, and the vertebral column is also, this is the middle of your back. So you push on your back, look at how much distance there is between the skin and the bones. You may feel like you're pushing on the bones, but you're not. You're a long way from them. And you can see the slips of white, bright white, immediately around the lungs. Those are ribs. And then those sort of irregular looking white structures posteriorly are the shoulder blades, which are attached by muscles and by ligaments to the chest wall there posteriorly. So we follow this down. And now we're seeing another structure opening up next to our trachea. Well, what's that? That black structure just to the left of the trachea. Well, that is just above the split, the carina, where the trachea divides into the two main stem bronchi, a right and a left, and the left comes off at a flatter angle, the right is steeper, and that black thing there is a secondary bronchus that takes off from that primary bronchus right after the split. So you have your main stem bronchi splitting off, and then immediately you've got a secondary bronchus going up to the left upper lobe there on the left. On the right, you can see that one coming off to the right upper lobe, and they continue to split, and they get smaller and smaller and divide further and further, and eventually you make your way down to the bronchioles and then the alveoli. In the meantime, right in the center of the chest, we've got our aorta and then our heart. So by the time we get to the heart, the airway has already divided into the main stem bronchi. There's no longer a central airway structure. We're now feeding the lungs. We continue down, that's the heart in the middle there. It's right behind the sternum in the front, slightly to the left, squishing the left lung more than the right, and that's why most likely we've got 3 lobes on the right and only 2 plus the little tiny lingula, which is probably just a squished third lobe on the left. So we follow our way down. You can see now there right behind the heart, you've got the aorta, and between the two you've got the esophagus. You can see it there. You come down and it's held open a little more. Now we're getting anteriorly this sort of fuzzy gray structure. What's that? That's the diaphragm. That big slip of muscle. It's attached anteriorly at the bottom of your ribs, and posteriorly it extends much more inferiorly down to the ribs in the back. So your lungs essentially end anteriorly more or less at the inferiormost rib, and your heart ends there, the diaphragm comes across. But posteriorly the lungs continue to extend down quite a bit more. So now we've got other structures there. On the patient's right, we've got that gray structure with white lines through it. That's the liver. On the left, we've got the stomach, we've got the spleen, and they're in front of posterior lung. So those inferior lobes are extending all the way down behind these structures. And we've got bowel, the pancreas is in the middle there. We keep coming down, and we've still got lung. We were seeing almost the entire spleen. We're seeing almost the entire liver. We've got all sorts of bowel. We've got the pancreas is that thing that almost looks like a caterpillar that goes up in the middle and comes down. And we're actually starting to see the top of the kidneys here. And we've still got a little bit of lung there posteriorly on the right. And so it's only here at the very inferior most posterior ribs that we're finally no longer filling that space with lung. We're now entirely into the retroperitoneum and the abdominal cavity. So that is your airway from top to bottom. We're going to go through to the beginning, and then we're just going to kind of come down like a movie. You can watch it flash its way through, get a sense again of the relationships of the structures of the airway, and hopefully this will make you feel much more comfortable with what you're doing when you're managing an airway, what the relationship of all the various structures are to each other. So we're zooming back up towards the top of the head, mouth, nasopharynx, up to the very top here, to the orbits, to the sinuses. Okay, ready? Here we go. And that's your airway. So thank you very much for your attention, and if you have any questions, feel free to contact me.